Welcome. In this session, we'll be discussing the major clinical trials in non-proliferative diabetic retinopathy and diabetic macular edema. We have discussed a few of these trials in the previous session and we'll be mentioning them as we proceed through this session. We have discussed the metabolic control trials in the previous session, and this includes the DCCT, UKPDS, ACCORD and the field trials. The early treatment for diabetic retinopathy study was a landmark clinical trial in the pre-anti-VEGF era, which included 3711 patients and was a complexly designed study evaluating the efficacy of various combinations of focal and grid photocoagulation and scatter photocoagulation, as well as efficacy of aspirin on retinopathy progression and visual loss, both moderate visual loss and severe visual loss in eyes with disease severity ranging from mild NPDR to non-high risk PDR. We have defined mild NPDR in the previous session and we'll be discussing non-high risk PDR in the next. ETDRS Report 1 evaluated the efficacy of focal laser in eyes with mild or moderate NPDR and DME. 754 eyes were assigned to immediate focal laser and 1450 eyes were assigned to deferred focal laser treatment. Moderate visual loss, defined as decrease of 15 or more letters on the ETDRS chart, was 12% in immediate focal laser group and 24% in deferred focal laser group at 3 years. And in eyes with CSME at baseline, the figures were 15% and 32%. We have discussed the definition of CSME in the previous session. So larger visual acuity differences were seen in patients with CSME, but in eyes without CSME, there was only a low rate of moderate visual loss regardless of treatment. So ETDRS Report 1 concluded that presence of clinically significant macular edema warrants treatment with focal laser photocoagulation. Grid laser was not mentioned in this study because grid laser was introduced after the publication of this study. ETDRS Report 9 was a complex design study with several randomizations. Eyes with severe NPDR and without macular edema were randomized to either early PRP or deferred PRP. Eyes with less severe NPDR and macular edema were randomized to several laser protocols, including both focal and PRP lasers. And eyes with severe NPDR and macular edema were also randomized to several laser protocols, including both focal and PRP lasers. ETDRS Report 9 concluded that in eyes with macular edema and severe NPDR or early PDR, immediate focal plus delayed PRP laser is the strategy of choice, and also that in eyes with severe NPDR, although immediate PRP decreases the risk of conversion to high-risk PDR as compared to deferral of PRP till high-risk characteristic PDR develop on follow-up, immediate PRP is not recommended in eyes with severe NPDR but should be done only when high-risk characteristic PDR develops. This is because immediate PRP results in increased moderate visual loss in the first few months by increasing macular edema or inducing macular pucker, and also because severe visual loss occurred only in 4% of eyes in deferred PRP till high-risk characteristic develop on follow-up group as compared to 2.5% of eyes in immediate PRP group. Similarly, ETDRS Report 9 also recommended against scatter laser for mild and moderate NPDR. We have grouped the studies into anti-VEGF trial group and steroid trial group, and we'll find that some of these trials were actually comparisons of anti-VEGFs and steroids, and we have grouped these trials into either of these groups based on their main aim and result. Protocol I of Diabetic Retinopathy Clinical Research Network was the first trial evaluating efficacy of anti-VEGFs in diabetic macular edema, and Protocol I compared 4 treatment groups among patients with diabetic macular edema involving center of macula and visual acuity between 2032 and 2320. The 4 treatment groups were ranibizumab plus prompt laser, ranibizumab with deferred laser beyond 24 weeks, triamcinolone with prompt laser, and laser with sham injections. The ranibizumab groups received ranibizumab injections once monthly for 16 weeks, followed by once a month evaluations and as required injections. Laser was part of the treatment protocol in each of the 4 groups and was repeated as required at a minimum of 13-week interval. And in the triamcinolone group, triamcinolone was repeated as required at a minimum 16-week interval. Protocol I showed superior BCVA results of ranibizumab groups as compared to the triamcinolone group and no benefit of additional prompt laser. But in eye pseudophakic at baseline, triamcinolone group showed similar BCVA results as the ranibizumab groups. And at 1 year, reduction in retinal thickness was similar in ranibizumab and triamcinolone groups. So this table shows the results of the Protocol I at 1 year and at 2 years, and we find better visual acuity results of ranibizumab as compared to triamcinolone or laser. Even eyes with persistent DME at 24 weeks among those who received ranibizumab injections improved subsequently with continued as needed ranibizumab injections. The RISE and RHINE trials were two similarly designed phase 3 RCTs comparing efficacy of monthly ranibizumab injections of two doses 0.3 mg and 0.5 mg versus sham injections over a period of 24 months in patients with DME with central foveal thickness equal to or more than 275 microns and BCVA between 2040 and 2320. So in the RISE and RHINE trials, central foveal thickness instead of central subfield thickness was evaluated. 759 patients were included in this trial, and as part of the trial protocol, focal and/or grid laser could be administered beginning at 3 months if reduction in central foveal thickness was not adequate. At 24 months, both RISE and RHINE trials found superior visual gain and reduction in CFT in ranibizumab groups with no differences in these parameters between the two ranibizumab groups, and also fewer patients in ranibizumab groups showed 2 or more steps retinopathy progression or progression to PDR. A summary of the 24-month data of RISE and RHINE trials is given in this table. Patients in ranibizumab groups in both RISE and RHINE trials required less focal and/or grid laser therapy and less panretinal photocoagulation as compared to patients in sham groups. 4 patients in ranibizumab groups developed endophthalmitis, and total number of serious vascular events including death were almost similar in all groups in the two studies. In the third year of the study, between 24 and 36 months, patients in the ranibizumab groups continued to receive monthly ranibizumab injections, but patients receiving sham injections in the first 24 months crossed over to monthly 0.5 mg ranibizumab injections. Patients in the original ranibizumab groups continued to maintain visual and anatomic gains in the third year of the study, but patients in the original sham group who crossed over to ranibizumab in the third year seemed to have inferior outcomes at the end of 36 months of the two trials, as shown here in this table. In the open label extension phase of RISE and RHINE trials, conducted from 36 months to 60 months from baseline, patients were followed at least every 90 days and administered 0.5 mg ranibizumab on PRN basis, but only 367 completed 48 months of follow-up, and the 48-month results were reported. Among the patients who completed 48 months of follow-up since baseline, 24% of patients did not require any injections in the open label extension phase of the trial, and 76% required ranibizumab re-injections. And the status of diabetic retinopathy severity according to ETDRS DRSS criteria were also reported for these two groups. And regardless of change in DR severity, vision improvement was maintained in the open label extension phase of RISE and RHINE trials. The TREX-DME study evaluated the efficacy of treat and extend ranibizumab regimen for center-involved diabetic macular edema. 150 eyes were randomized to 3 groups, with the first group receiving ranibizumab 0.3 mg injections at 4 weekly intervals till 2 years, the second group receiving a loading dose of 4 ranibizumab 0.3 mg injections at 4 weekly intervals, followed by ranibizumab injections in a treat and extend protocol till 2 years, in which the intervals between 2 consecutive ranibizumab injections could be extended to a maximum of 12 weeks. and a third group receiving a loading dose of 3 injections of ranibizumab 0.3 mg at 4 weekly intervals, followed by ranibizumab injections in a treat and extend regimen till 2 years, in which the interval between 2 consecutive ranibizumab injections could be extended to a maximum of 12 weeks. But the third group also received laser at week 4, and the laser could be repeated at 3 monthly intervals as required with a navigated laser device. And after 2 years, participants in all groups received ranibizumab in a PRN regimen. At 2 years, the TREX-DME study found that the treat and extend cohorts required significantly fewer number of injections and gave anatomical, that is retinal thickness results, and visual gain, that is BCVA results, similar to the regimen of monthly ranibizumab injections, and the result was maintained till 3 years since baseline. And there was no difference between the treat and extend cohort and the treat and extend plus laser cohort as regards number of injections. VIVID and VISTA were two similarly designed phase 3 RCTs conducted in different countries, evaluating efficacy of intravitreal aflibercept as compared to macular laser photocoagulation in patients with centered involved DME and visual acuity between 20/40 and 23/20. 872 eyes were included in this study and were randomized to 3 groups. First group receiving intravitreal aflibercept 2 mg injections at 4 weekly intervals. The second group receiving 5 intravitreal aflibercept 2 mg injections at 4 weekly intervals, followed by intravitreal aflibercept 2 mg injections at 8 weekly intervals, and the third group receiving macular laser photocoagulation, which could be repeated after 12 weeks. The protocol of VIVID and VISTA also included that after 24 weeks, eyes in intravitreal aflibercept group could receive laser, and eyes in laser groups could receive intravitreal aflibercept if required. At 52 weeks, aflibercept groups demonstrated significant superiority in visual acuity gains and retinal thickness reduction outcomes as compared to laser photocoagulation, but there was no difference between the two aflibercept regimens, and the incidence of systemic adverse events were similar across all groups. In the VIVID and VISTA trials, the treatment regimen was continued after 52 weeks. At 100 weeks, the study reported that the anatomical and functional superiority of intravitreal aflibercept over laser photocoagulation achieved at 52 weeks were maintained, with no significant difference between the two aflibercept regimens. Safety was consistent with the known safety profile of intravitreal aflibercept. Similarly, at 148 weeks, the study reported that the superiority of intravitreal aflibercept in functional, that is BCVA gain over laser, achieved at 52 weeks and 100 weeks were maintained, with no significant difference between the two aflibercept regimens, and the incidence of adverse events were consistent with the known safety profile of intravitreal aflibercept. Protocol V evaluated and compared the role of aflibercept laser and observation in patients with centered involved DME and good visual acuity of 20/25 or better. 702 eyes were randomized to 3 groups. The first group receiving aflibercept 2 mg injections every 4 weeks for at least 24 weeks and further till there was no improvement or worsening of BCVA and central subfoveal thickness from previous visits. This group could receive laser photocoagulation after 24 weeks if required. The second group receiving laser photocoagulation at baseline, which could be repeated at a minimum of 13 or more weeks interval. And the third group was the observation group. The protocol also included that eyes in laser photocoagulation and observation groups could receive aflibercept after 8 weeks from baseline if visual acuity worsened by 10 or more letters from baseline. At 2 years, Protocol V found that in eyes with centered involved DME and BCVA of 20/25 or better, there was no significant difference in vision loss whether they were managed initially with aflibercept laser or observation and given aflibercept only when BCVA worsened. and aflibercept injection was required in 1/4 of eyes in initial laser group and 1/3 of eyes in the initial observation group in the 2 years of the trial. The PANORAMA trial compared the efficacy of aflibercept versus sham in eyes with severe NPDR but without center-involved DME and having BCVA of 20/40 or better in preventing progression of retinopathy. 402 patients were randomized to 3 groups, with the first group receiving a loading dose of 3 4-weekly aflibercept 2 mg injections, then another aflibercept 2 mg injection after 8 weeks, and then aflibercept 2 mg injections every 16 weeks. The second group receiving a loading dose of 5 4-weekly aflibercept 2 mg injections, followed by aflibercept 2 mg injections every 8 weeks till week 56, and then aflibercept 2 mg injections PRN, and the third group receiving sham injections. And rescue treatments with aflibercept PRP or vitrectomy for vision-threatening retinopathy and CHIDME was available for all groups. And the PANORAMA trial found that significantly more eyes receiving aflibercept had 2 or more DRSS steps improvement, and significantly fewer eyes receiving aflibercept had vision-threatening complications and or center-involved DME as compared to eyes receiving sham injections. Protocol W of DRCR evaluated the efficacy of quarterly aflibercept injections versus sham in reducing the risk of developing PDR or center-involving DME in eyes with moderate to severe NPDR over 4 years. And Protocol W reported that fewer patients in aflibercept group as compared to patients in sham group developed PDR or center-involving DME, but there was no difference in mean change in visual acuity from baseline between the 2 groups. So Protocol W did not recommend routine use of aflibercept for preventing progression of retinopathy, but FDA has approved the use of ranibizumab and aflibercept for preventing the progression of diabetic retinopathy. Protocol T of DRCR was a very important trial comparing the efficacy and safety of aflibercept, bevacizumab and ranibizumab in the treatment of center-involved DME eyes with visual acuity between 2032 and 2320 and with central subfield thickness above eligibility threshold, which is defined here. The eligibility threshold includes a central subfield thickness of 250 microns or more on Zeiss stratus, which is a time domain OCT, a CST of 305 microns or more in males and 290 microns or more in females on Zeiss Cirrus, which is a spectral domain OCT, and a CST of 320 microns or more in males and 305 microns or more in females on Heidelberg Spectralis, which is also a spectral domain OCT, and these figures as mentioned here have now become standard. Protocol T included a total of 660 eyes which were randomized to 3 groups, one receiving aflibercept 2 mg injections, the second receiving bevacizumab 1.25 mg injections, and the third receiving ranibizumab 0.3 mg injections. In each of the 3 groups, injections were given every 4 weeks, either till visual acuity was 20/20 or better with CST below eligibility threshold, or till there was no further improvement or worsening since the last 2 injections. And follow-up evaluations were conducted every 4 weeks, and injections were restarted if worsening was detected during follow-up. In Protocol T, focal and/or grid laser could be initiated in any of the 3 groups at and after 24 weeks for persistent DME if the following criteria were present, and laser could be repeated if there was no improvement since last laser and only after 13 weeks or more. At the end of 1 year, Protocol T found that the relative effect of the 3 drugs depended on baseline visual acuity. In patients with baseline visual acuity of 20/40 or better, there was no difference between the 3 drugs as regards improvement of base-corrected visual acuity, but in patients with baseline base-corrected visual acuity of 20/50 or worse, aflibercept was more effective in improving base-corrected visual acuity in comparison to both ranibizumab and bevacizumab, difference between which was not significant. And in all patients, CST reduction was significantly more in aflibercept and ranibizumab groups as compared to bevacizumab group, with no significant difference between aflibercept and ranibizumab. Protocol T also found that among eyes with NPDR at baseline, a smaller proportion of eyes in bevacizumab group as compared to eyes in ranibizumab and aflibercept groups showed 2 or more DRSS steps improvement in DR status. And there was no significant difference among the 3 treatment groups in incidence of systemic adverse effects. This table shows the overall mean change in BCVA and CST in the 3 treatment groups at 1 year. This table shows the mean changes in BCVA and CST in patients with baseline visual acuity of 20/40 or better, and this table shows the mean changes in BCVA and CST in patients with baseline visual acuity of 20/50 or worse. After 1 year, the study protocol remained same except that follow-up intervals were extended to 4 to 16 weeks depending on treatment outcomes. At the end of 2 years, Protocol T found that in eyes with baseline BCVA of 20/40 or better, BCVA gains were similar among the 3 treatment groups as at the end of 1 year. But in eyes with BCVA of 20/50 or worse, BCVA gains were significantly better with aflibercept as compared to bevacizumab, but differences between aflibercept and ranibizumab as well as between ranibizumab and bevacizumab were not significant. Also, at the end of 2 years, in eyes with baseline BCVA of 20/40 or better, CST reduction from baseline was significantly more in aflibercept and ranibizumab groups as compared to bevacizumab group as at the end of 1 year. But in eyes with BCVA of 20/50 or worse, differences in CST reduction was significant only in comparison between aflibercept and bevacizumab. These 3 tables show the 2-year results of Protocol T. The number of injections required in the second year was less than that in first year, and serious systemic adverse effects were higher in the ranibizumab group. Also, as regards 2 or more DRSS steps improvement in diabetic retinopathy status among eyes with NPDR at baseline, there was no significant difference between the 3 treatment groups. After 2 years, patients were treated at clinician's discretion as regards selection of the drug, and this part of the trial was called Protocol TX. 317 eyes completed the study till 5 years, and at the end of 5 years, Protocol TX found that the mean retinal thickness were similar at the end of 2 years and at the end of 5 years, but BCVA declined between these 2 time points as shown here in this table. Protocol AC of DRCR compared the efficacy of initial treatment with aflibercept versus bevacizumab in eyes with center-involved DME and BCVA between 20/50 and 23/20. With eyes in initially bevacizumab group receiving aflibercept later in the study if required. 312 eyes were randomized to 2 groups, with the first group receiving aflibercept 2 mg injections every 4 weeks until success or sustained stability was achieved. Following this, follow-up was maintained at 4-week intervals in the first year and 4 to 16-week intervals in the second year, and injections were resumed when BCVA or CST worsened, and the second group receiving bevacizumab 1.25 mg injections every 4 weeks until success or sustained stability is achieved. But from 12-week onwards, eyes in this group received aflibercept if predefined criteria were met. At 2 years, Protocol AC found that there was no difference in visual outcomes between the 2 groups, but 70% of eyes in initially bevacizumab group ultimately required aflibercept. KESTREL and KITE were similarly designed phase 3 trials comparing the efficacy of brolucizumab versus aflibercept in the management of center-involved DME with best-corrected visual acuity of 2032 to 2400 and CST of 320 microns or more. KESTREL and KITE were conducted in different parts of the world, and in total 566 eyes were randomized to 3 groups, the first receiving brolucizumab 3 mg, the second receiving brolucizumab 6 mg, and the third receiving aflibercept 2 mg injections. The brolucizumab 3 mg injection cohort was present only in the KESTREL study. The brolucizumab groups received a loading dose of 5 every 6 weekly injections, followed by injections every 12 weeks or if required every 8 weeks, and the aflibercept group received a loading dose of 5 every 4 weekly injections, followed by injections every 8 weeks. At 52 weeks, the study concluded that brolucizumab 6 mg was non-inferior to aflibercept 2 mg in improving visual acuity and showed robust visual gains and anatomic improvement with an overall favorable risk-benefit profile in patients with DME. But brolucizumab 3 mg injections did not show non-inferiority to aflibercept 2 mg in visual acuity gains in the KESTREL study. Also, anatomical outcomes reduction in CST and intraretinal and subretinal fluid resolution favored brolucizumab over aflibercept. This is similar to the Hawk and Harriet trials of brolucizumab versus aflibercept in neovascular AMD. So this table shows the 52 weeks result in the KESTREL and the KITE studies, and the median number of injections required were 7 in the brolucizumab group and 9 in the aflibercept group, and more than half of patients in the brolucizumab 6 mg group in the two trials could be maintained on 12-weekly dosing intervals after the loading dose. Overall, ocular and systemic adverse effects were comparable between the groups within each trial, and the incidence of intraocular inflammation and retinal vasculitis, which are of concern with brolucizumab, is mentioned here. After 52 weeks, the intervention was continued, except that in the KITE trial, after week 72, treatment intervals in brolucizumab 6 mg group could be extended by 4 weeks based on stability of disease activity. So those receiving brolucizumab 6 mg at 8-weekly interval could be extended to 12-weekly interval, and those receiving brolucizumab at 12-weekly intervals could be extended to 16-weekly intervals in the KITE trial after week 72. At 100 weeks, or approximately 2 years since baseline, results showed long-term efficacy and durability of brolucizumab in improving visual and anatomical outcomes in diabetic macular edema, and the overall safety profile of brolucizumab remained unchanged. Fewer patients on brolucizumab 6 mg had intraretinal and subretinal fluid in both KESTREL and KITE trials. This table shows the 100-week results of the KESTREL and KITE trials. And in the KITE trial, 47.5% of brolucizumab patients could achieve a dosing interval of 12 weeks or longer, with 24.8% achieving a dosing interval of 16 weeks at 100 weeks since baseline. And in the KESTREL trial, 32.9% could achieve a 12-weekly dosing interval at 100 weeks since baseline. Overall, ocular and systemic adverse effects were comparable between the groups within each trial, and the incidence of intraocular inflammation and retinal vasculitis are mentioned here. The YOSEMITE and RHINE trials were similarly designed phase 3 trials comparing the efficacy of faricimab versus aflibercept in the management of diabetic macular edema with BCVA between 2032 to 2400 and with CST of 325 microns or more. Eyes previously treated with anti-VEGF were also included in these two trials, but limited to 25% of total enrollment. In these two trials, 1891 patients were randomized to 3 groups, with the first group receiving a loading dose of 6 faricimab 6 mg injections at 4 weekly intervals, followed by faricimab 6 mg injections at 8 weekly intervals. The second group receiving a loading dose of 4 or more faricimab 6 mg injections at 4 weekly intervals till CST first reached 325 microns or less, followed by treat and extend regimen with injection intervals extended in 4 weekly steps up to 16 weeks based on pre-specified CST and BCVA criteria, and the third group receiving a loading dose of 5 aflibercept 2 mg injections at 4 weekly intervals, followed by aflibercept 2 mg at 8 weekly intervals. At 52 weeks, the YOSEMITE and RHINE trials concluded that robust visual gains and anatomical improvement were achieved with adjustable dosing intervals of faricimab of up to 16 weeks, demonstrating the potential of faricimab to extend the durability of treatment, and incidence of ocular adverse effects were found to be the same in the 3 groups in the 2 trials. At 100 weeks, the YOSEMITE and RHINE trials concluded that clinically meaningful visual acuity gains from baseline anatomic outcomes and extended durability of treatment of up to 16 weekly faricimab 6 mg injection intervals could be maintained till 2 years, and the mean reduction in central subfield thickness was significantly more in the 2 faricimab groups as compared to the aflibercept group in both the trials. and the incidence of serious ocular and non-ocular adverse events were low and comparable between the groups in both the trials. So this table shows the results at 100 week in the YOSEMITE and RHINE trials, and fewer number of injections were required in the faricimab treat and extend cohort, with 78% of patients in faricimab treat and extend cohort in each of YOSEMITE and RHINE trials achieving 12-week or more dosing intervals, and 60% and 65% of patients in faricimab treat and extend cohorts of YOSEMITE and RHINE trials respectively achieving 16-week dosing intervals. Then we have the trials of intravitreal steroids in diabetic macular edema, and Protocol B of DRCR evaluated the safety and efficacy of 2 doses of triamcinolone acetonide 1 mg and 4 mg versus focal and/or grid photocoagulation in patients with diabetic macular edema involving fovea and visual acuity between 20/40 and 23/20 over a period of 2 years. 840 eyes were randomized to receive either focal and/or grid photocoagulation, 1 mg triamcinolone acetonide or 4 mg triamcinolone acetonide, and treatment could be repeated in each of these groups for persistent or new edema at a minimum of 4-month intervals. At 2 years, Protocol B concluded that focal and/or grid laser photocoagulation was more effective with respect to functional as well as anatomic outcomes, with less side effects than the 2 triamcinolone doses. And at 3 years, the findings were similar. So this table displays the findings of Protocol B at 2 years and at 3 years. FAME was a phase 3 RCT evaluating the safety and efficacy of fluocinolone acetonide implant in patients with diabetic macular edema. 953 eyes with persistent DME, despite having received at least 1 laser procedure, were randomized to 3 groups. The first receiving fluocinolone acetonide implant releasing 0.2 microgram of fluocinolone per day, the second receiving fluocinolone acetonide implant releasing 0.5 microgram of fluocinolone per day, and the third group receiving sham injections. Injections were given at baseline and could be repeated only after 1 year, and in each of the 3 groups, focal and/or grid laser could be done after 6 weeks from baseline as required. At 2 years, both low and high dose fluocinolone implants demonstrated significant superiority in BCVA gains as compared to sham injections, and visual gains were better in eyes that were pseudophakic at baseline. Risk-benefit ratio was superior in the low dose implant as compared to the high dose implant, and at 3 years the results were maintained. PALADIN was a phase 4 non-randomized study evaluating the safety and efficacy of fluocinolone acetonide 0.19 mg implant in DME patients who previously received ocular steroids without clinically significant rise in intraocular pressure. 202 eyes were included in the PALADIN study. The PALADIN study found that fluocinolone acetonide 0.19 mg implant improved visual acuity and reduced treatment burden as compared with previous treatments for DME, while maintaining a favorable safety profile. The mean treatment frequency was 1 implant per year, which was a 70.5% decrease from 3.4 injections per year in the study patients prior to inclusion in the study. And 96.92% of eyes who had an IOP less than 25 mm of mercury to pre-study steroid challenge had similar IOP outcomes at the end of study. The MEAD was a phase 3 RCT evaluating the safety and efficacy of dexamethasone implant in patients with DME having BCVA between 2040 and 2200 and CST of 300 microns or more over a period of 3 years. 1048 patients were randomized to 3 groups, with the first group receiving dexamethasone 0.7 mg implant, the second group receiving dexamethasone 0.35 mg implant, and the third group receiving sham injections. In the MEAD trial, dexamethasone injections could be repeated at a minimum interval of 6 months if CST was 225 microns or more, and cataract surgery and PRP were allowed during the study. The MEAD trial found that visual acuity gains and reduction in central subfield thickness was significantly higher in dexamethasone implant groups as compared to sham. And this table shows the 3-year results of the MEAD trial. The BEVORDEX compared the efficacy of dexamethasone versus bevacizumab and randomized a total of 88 eyes to receive either bevacizumab every 4 weeks as required or to receive dexamethasone implant every 16 weeks as required. At 2 years, the BEVORDEX study reported that the proportion of patients gaining 10 letters or more and reductions in central retinal thickness are similar between dexamethasone and bevacizumab groups. And in the dexamethasone group, the mean gain in base-corrected visual acuity in terms of ETDRS letters gained was higher in eyes pseudophakic at baseline as compared to eyes phakic at baseline, and this finding corroborated with the famed trial on fluocinolone acetonide in DME. As expected, the incidence of cataract and rise in intraocular pressure was higher in dexamethasone group as compared to bevacizumab group, but the number of injections required were less in dexamethasone group as compared to bevacizumab group, and the difference in the total number of injections required in the two groups was higher at the end of 2 years. The CHAMPLAIN study was a prospective uncontrolled study demonstrating the efficacy of dexamethasone implant in vitrectomized eyes with diabetic macular edema. Protocol U of DRCR evaluated the efficacy of combined therapy with ranibizumab and dexamethasone implant versus ranibizumab only in eyes with persistent diabetic macular edema. A total of 129 eyes with center-involved DME with central subfield thickness meeting eligibility criteria as discussed before and with best-corrected visual acuity between 2032 and 2320 after receiving at least 6 4-weekly ranibizumab injections were included and randomized into two groups. One group receiving ranibizumab and dexamethasone injections and the other group receiving ranibizumab and sham injections. All patients were followed up every 4 weeks, and at every visit, if CST met eligibility criteria and BCVA was worse than 20/50, ranibizumab injection was given alone or in combination with dexamethasone or sham injections, according to protocol. At 24 weeks, Protocol U concluded that although use of dexamethasone was more likely to reduce retinal thickness, it does not improve best-corrected visual acuity over and above that achieved with continued ranibizumab injections alone. And this table shows the 24-week data from Protocol U. Other relevant trials on diabetic macular edema and non-proliferative diabetic retinopathy, which we have discussed in the previous session, are the Protocol AA, Protocol D, and Protocols B and Q. To recap the salient points, ETDRS Report 1 recommended focal and/or grid laser photocoagulation in eyes with clinically significant macular edema to reduce the risk of moderate visual loss. ETDRS Report 9 recommended immediate focal and/or grid laser photocoagulation and deferred panretinal photocoagulation till high-risk characteristic PDR develops in eyes with macular edema and severe NPDR or early PDR. DRCR Protocol I demonstrated superior visual acuity gains with ranibizumab in centered involved DME as compared with triamcinolone with or without focal and/or grid laser photocoagulation, but eyes pseudophakic at baseline showed similar BCVA gains with triamcinolone as compared with ranibizumab. RISE and RHINE showed superior visual acuity gains and CFT reductions and lower risk of retinopathy progression with ranibizumab as compared with sham injections in eyes with centered involved DME. VIVID and VISTA trials demonstrated superior visual acuity gains and CST reductions and higher chance of improvement in retinopathy with aflibercept as compared to focal and/or grid laser photocoagulation in eyes with centered involved diabetic macular edema. DRCR Protocol V showed that in eyes with centered involved DME and visual acuity of 20/25 or better, observation is acceptable, but aflibercept should be administered if there is any worsening of visual acuity. DRCR Protocol T compared the efficacy of ranibizumab, bevacizumab, and aflibercept in centered involved DME. It concluded that in eyes with baseline visual acuity of 20/40 or better, the efficacy of the three drugs in improving BCVA was similar, but in eyes with baseline BCVA of 20/50 or worse, aflibercept was superior to both ranibizumab and bevacizumab in improving best corrected visual acuity. KESTREL and KITE trials demonstrated that brolucizumab was non-inferior to aflibercept in improving best-corrected visual acuity in eyes with centered involved DME, but reduction in CST was higher with brolucizumab than with aflibercept. Also, injection intervals could be extended to 12 weeks or more in a significant proportion of patients in brolucizumab groups. YOSEMITE and RHINE trial showed that faricimab was non-inferior to aflibercept in improving best-corrected visual acuity in eyes with centered involved DME, but eyes in faricimab groups had a higher reduction in CST as compared to eyes in the aflibercept groups. More than half of patients in faricimab groups could achieve a dosing interval of 16 weeks. DRCR Protocol B showed that focal and/or grid laser photocoagulation achieved superior base-corrected visual acuity results with fewer side effects as compared with triamcinolone. The FAME study demonstrated superior BCVA gains with fluocinolone implant as compared with sham in eyes with DME, and BCVA results were better in eyes pseudophakic at baseline. The MEAD trial showed that dexamethasone implants achieved superior best-corrected visual acuity gains and central subfield thickness reductions in eyes with center-involved diabetic macular edema as compared with sham. DRCR Protocol U compared the efficacy of ranibizumab versus ranibizumab and dexamethasone in centered involved diabetic macular edema. It concluded that although addition of dexamethasone could achieve a higher reduction of central subfield thickness, it did not affect best-corrected visual acuity outcomes. Protocol U, MEAD and FAME trials all demonstrated the higher risk of cataract, raised intraocular pressure, and the need for their surgical treatments in eyes receiving intravitreal steroids. However, the PALADIN study, which was an uncontrolled study evaluating fluocinolone for diabetic macular edema, showed that 96.92% of eyes with IOP response of less than 25 mm of mercury to pre-study steroid challenge had similar IOP outcomes at the end of the study. Thank you for listening.